Throughout the summer months, of course, we have all turned our health focus to the concerns about skin cancer, and rightly so. But for men, prostate cancer is actually still high on the list of risks that you need to keep in mind when you're looking at your overall health. There's a new study out we're going to tell you about this morning. Dr. Lee Jackson is back from CHI Memorial. He is a robotic prostate surgeon there. Good to see you.
Well, thank you for having me back.
Do I have my facts and figures correct? So skin cancer is the #1 concern for men, prostate cancer the second?
Correct, yes. The numbers with prostate cancer are very similar to breast cancer numbers for women. About 200,000+ women are diagnosed with breast cancer, and the numbers are the same for men with prostate cancer.
So just like we think about with breast cancer, there being a proclivity in family genes to develop that, is that also true in prostate cancer?
Absolutely. Prostate cancer is one of the most inherited cancers, so having a family history of prostate cancer is an important risk factor.
I mentioned some new findings, a new study. This is critical for the diagnosis of prostate cancer.
Yes, there's been a lot of controversy, and we've talked about it before here and on your radio show about the value of PSA screening. And the problem, I think, has always been how we've investigated risk for prostate cancer. And just this past March, a very convincing article was published in the New England Journal of Medicine validating the use of MRI to investigate risk for prostate cancer. What we used to do, and still do, is use ultrasound-guided biopsies. This is one thing that does frighten men and kind of keeps them from pursuing screening for prostate cancer. But it's important to screen for prostate cancer because it's a silent disease in its early stages. If we wait for symptoms, we're going to find it when it's too advanced to really have many options for treatment. So we need to look for it. PSA has been what we've been using for 30 years, and it's been controversial. Back in 2012, the U.S. Preventative Services Task Force, in fact, recommended against using PSA. But that was misdirected. They've walked that back just this past year. The problem was how we investigated it, and we've investigated it for 30 years with ultrasound-guided biopsies, which was a systematic but blind method of investigating it. It was a blind biopsy. That led to a couple of problems. One was it would stumble across an indolent form of prostate cancer that we really didn't need to know about. This is overdiagnosis. Led to a lot of anxiety and to overtreatment and harm. It could also miss a clinically important prostate cancer. So a very common situation was you had a man that you suspected was at risk for prostate cancer because of his PSA or other risk factors like ethnicity and family history. He went through an ultrasound-guided biopsy and all the results were benign. The question remained, is he really free of prostate cancer or did we miss something? And that led to subsequent biopsies. That caused people to question the value of PSA.
Sure.
So in recent years, MRI has come along as a much more effective way of investigating risk for prostate cancer. And again, just this past March, we finally have a study that validates that, and it reproduces similar results from a study that was published back in 2017.
Okay, so if MRI now is the recognized preferred way to diagnose it, then when you talk about the risk factors, how do you determine when you get the MRI to detect if there's a cancer there and not?
Okay, so the first step is getting the PSA and then interpreting that PSA in the context of other risk factors such as African American ethnicity and family history, and also interpret it in the context of age group. Different age groups have different norms for PSA. So if someone has other risk factors or a PSA that is persistently outside of the expected range, then we have clinical suspicion that he may have prostate cancer, and we need to investigate that. So instead of going right to a biopsy, we can now further evaluate their risk with an MRI. What this study confirmed was that you can avoid a biopsy in 28% of the men. So just over 1 out of 4 men won't need a biopsy at all.
That's good news.
That's very good news, and that should give men some comfort that they're not just going to be blindly biopsied or automatically biopsied. They're going to be evaluated, and if they are indeed at risk, there's a suspicious lesion noted, then that can be targeted with the MRI, which also has its advantages. But most men are relieved to learn that, well, I may not need a biopsy, and the MRI can tell us that.
So what are the screening guidelines? At what age do you recommend men get their first PSA check or screening?
It's a more complicated question than many realize, because there are many guidelines depending on the society. But I think it's well accepted that men in their 40s should have a baseline PSA. It's one of the strongest predictors for their lifetime risk of developing a clinically important prostate cancer. And their PSA in their 40s should be less than 1, on the order of 0.6 or 7.
Okay, so if there is a family history, women know this with breast cancer, then do you be upfront with your doctor and perhaps you make a joint decision, okay, let's screen you even sooner than in your 40s?
Absolutely. If someone has a family history, they should be discussing that risk, make a shared decision, and begin annual or every other year biennial PSA screening.
Okay, with the MRI and the ability it sounds like it has to see specifically certain points there, then if you find something, and that's not good news, does the ability of that MRI to detect the specific area benefit you then in how to treat?
Yes. First of all, it virtually eliminates the risk that we're going to miss the cancer, because we can see the area in the prostate that is suspicious, or the radiologist can, and then use that image to target a biopsy. You require fewer needle sticks, so that's less invasive. You also get staging information from that. You already know whether or not that suspicious area is confined to the prostate or outside of the prostate.
And if someone's watching today and they have not followed perhaps the recommendations, or maybe they even have, but they're finding themselves, they think, symptomatic, what are some things to watch for? And when you call your office and you make that clear, does that affect how quickly you get in to be seen?
Well, if someone is having symptoms that suggest the presence of prostate cancer, we're usually dealing already with advanced disease, so that does add some urgency to it. Before PSA, the most common symptom was related to bone metastases, so they had severe back pain or skeletal pain. Lower urinary tract symptoms, progressive difficulty passing their urine, or pain or blood. These kinds of things can be due to benign disease, certainly, but prostate cancer is one of the things you worry about. It's better if we can find it before we get to that stage, though. And
that's what they're doing in their office all the time, is looking at the next thing that's effective to bring to their patients here in Chattanooga. You'll find him at CHI Memorial. Again, it's robotics for prostate cancer. That's a great word to be able to use when it comes to that procedure. 495-3068 is the phone number. And you can go to chimemorialmedicalgroup.org and just /prostate to go online. Thank you, Dr. Jackson.
Well, thank you.